Yeah, let's get started. Good morning and welcome to day 2 of the Maverick Immersive Impact Conference. I'm so happy to have the Chesapeake Digital Health Exchange co-sponsoring this year's Maverick Conference. Yesterday's program was filled with great examples of XR, from analyzing climate change from space to peering inside a diesel engine. Today we have 3 full tracks of presentations and content with a fairly heavy emphasis on healthcare. Today we feature speakers from Johns Hopkins, MD Anderson Cancer Center, and Johnson & Johnson, among others. We're all seeking to improve the practice of medicine and patients' health and well-being, as well as featuring some of the most innovative applications from cutting-edge startups. I'd like to thank Lucian and the folks at Maverick for including us at the Chesapeake Digital Health Exchange in the 2020 Maverick Conference. I'd also like to thank the Johns Hopkins University and the University of Maryland for making this conference possible. We'd also like to thank the U.S. Department of Commerce for their generous support. The attendees should feel free to submit questions to chat, and we'll try to get to them in the course of this session. You should also feel free to interact with the speakers and the other attendees through the chat and Q&A functions. Please reference the program for Zoom links to specific other tracks. And now, on with the show. Our first presenters are Dr. Daniel Shuba. Whoop, guys on? First presenters are Dr. Daniel Shuba from Johns Hopkins and Nissan Elimelech, who's CEO of Augmedix. Nissan and his team have really pioneered this technology that uses augmented reality for spinal surgery, describing it, and I believe, Dan, you described it as using X-ray. You can almost have X-ray vision on the patient. So with that as an intro, I think I'll leave it to you guys to talk about the technology and talk about its application in VOR. Take it away, guys.
Thank you very much, Mark. I first want to introduce myself. As Mark said, I'm Nissan. I'm the founder and the CEO of Augmedix, and I'm a biomedical engineer by training. Let me share the screen so I can share with you some of the images here. I want to share with you how it all started, how I started the company, and where it all came from. So let me minimize this. So this was my previous life. I'm a biomedical engineer by training, as I said, and I worked about 10 years in the medical device industry as a sales rep, product manager, marketing in various fields of surgery. Before I started Augmedix, I worked in Medtronic for a few years in the spine surgery unit in Israel. As you can notice, behind me was always the navigation system by Medtronic. That's a system that I helped selling together with my team. And a navigation system is actually very crucial in brain surgeries. You can almost not do any brain surgery without using a navigation system. It helps the surgeons to locate their instrument inside the brain without damaging the brain tissue. And it is used almost in 100% of the cases. There's a lot of installed base, and all the big companies have navigation system, including the company that I worked for, Medtronic. It was proven to be very successful, very accurate, reduce the time. You don't need to scan the patient and to expose anyone to radiation when you use a navigation system. However, these systems are very expensive. And that's what and there's also a lot of challenges in that. That's one of the things that I noticed when I sold a system like that into one of my customers. I could see that, they feel not intuitive. The use is not intuitive when they use it. They feel very uncomfortable when they put pedicle screws inside the patient. Just imagine that at the most critical moment when they need to place a screw inside the vertebra of the patient, they need to take their eyes away from the patient and look aside on a distant screen to navigate. That's because you have the screen not in the sterile field, far away from the sterile field. You have the camera and infrared camera that sometimes there's a line of sight interference and you lose tracking. All this, looking aside causes the surgeon's attention shift. It requires a long learning curve until they get used to the system. And on top of all this, these systems are quite expensive, about $250,000 to $500,000 for every system. That all brings to a very low adoption rate in spine surgery. And I actually saw that myself when I was working in Medtronic. I experienced that. Even if you scan a patient, using an X-ray, you still have to look aside to see the images. So My vision was, I was working in Medtronic together with my customers. My vision was, why can't we just make surgeons like Superman, like superheroes? They can have X-ray vision, can look straight at a patient and see the whole anatomy that they want to see and to accurately navigate their instruments. That was my vision. And I started investigating that field. And I thought, realistically, obviously we cannot give them Superman powers, but realistically, we can make something that, like build some sort of a glasses that X-ray glasses that they can wear and see all the images of the patient, like reconstructive images of the CT or MRI scan directly through the skin of their patient. That was my vision, and that made me to leave Medtronic and to start a company. In 2014, I decided to leave Medtronic, and I founded together with three of my previous founders. One of them is as chief of spine surgery in one of the big hospitals in Israel, and the other one was a technology guy. I started a company together with these two. These two partners that I had did not continue with me eventually because one of them is a surgeon. Obviously, doesn't have the time to run a startup, and the other one just lost interest in the time. So I wanted to share also one of the first ever video, or the concept, turning the vision into something realistic that, people can grasp. This is where our system comes very handy. Before surgery, the surgeon plans over the patient's CT, the exact location of the screws inside each vertebra. Then, in surgery, he wears augmented reality glasses, and he can see the pre-planned 3D drawing over the real patient, pointing exactly at the location and angle for the screw insertion. All he needs to do is just to take the instrument and to place it just over the object to drill the hole in the correct location. Obviously, that was a very early, feasibility test, or even a demonstration that I just wanted to create so people can understand what I'm thinking about. I took like off-the-shelf glasses by Epson, and I created this model, this demo by myself. I mean, just hooked some cables around and used a software that was available in the internet. And I, built a Sobon model, and I started to demonstrate that vision that I had. I was part of the accelerator in the Technion. It's one of the leading institution in Israel, technology institution, university in Israel. And we, surprisingly, we got a prize, the first prize of the accelerator. It's called the BSTEC. We got $10,000, and that was the jump start for the company. So with that money, we started to raise, more significant funding from the Israeli chief scientist, and we got accepted to the one of the Israeli incubators in Haifa. It's called Terra Lab. And we started gathering people around us. I mean, started to build a company. We had 5 people. We worked with a budget of $800,000 for 2 years. That's a lot of years now, considering the amount of money that we're spending today. I mean, this $800,000 would not, sustain us for maybe even a month now. So this is pretty amazing that, in retrospective, you look at how you build a company and what's the expenses, right? So we actually just were all in one crowded room, sitting all together and trying to figure this out, how to develop the, the system and what we actually need to do to make it happen. We looked on off-the-shelf products. There was a lot of experience in, back then in using augmented reality or virtual reality for medical purposes. I mean, it started actually like maybe even 30 years ago. Henry Fuchs, Nasir Navab did a lot of trials, but nothing really came to a real product. There's a lot of challenges. Once we started to work on that, we realized that there's a lot of challenges. I'm not gonna talk about now about all the technology barriers that we had to crack, but I can tell you that our IP portfolio is pretty thick, because of all the barriers that we had to, to solve to get to the device that we have right now. The fact is that we are the first for sure, but currently the only navigation system using augmented reality glasses for medical purposes at all. So, so this is a fact. That's something that a lot of companies actually struggle. We started to build a prototype, and that's how it looks. It's a very funny picture, you know, very early stages where we just took all the components and put it all together. Looks like a suicide bomber here. And there's a lot of other prototypes. We tested it all. We did, you know, from projection to the augmented reality lenses from the sides or from the app. And this is one of the tasks that I did. We had a lot of cameras. Now we have only one, and we did a lot of publication. I think what made us very successful was the early exposure. Sometimes, you know, entrepreneurs choose the stealth mode, but I rather, you know, I picked the other way. I wanted to show the world what we're doing, to share my vision, and to publish it everywhere. Stuart and I, Stuart is the CTO of the company. Stuart and I were traveling all around the world, showing our technology to everyone, participating in accelerators such as the Matic Innovator, demos, which is kind of unique because we didn't have anything, you know, we didn't have any finished product. That's Daniel Kraft with our systems actually hanging on the wall, on the tree, as you can see it. That's in Menlo. It's it's actually a pretty nice place, and we just destroyed one of the trees in Sand Hill Road, which is pretty funny. We participated in a lot of conferences showing our system. We even got to TechCrunch, as you can see here. We got to the finals of the Disrupt TechCrunch. So basically, we just, you know, we didn't have a final technology, nowhere near commercialization or clearance, but we just, you know, I just shoot all over. That's what I did. We started developing a more and more robust system, a mobile version, and then we put everything we had on a cart instead of putting it on a tree. We also had, you know, different visualization styles. In the beginning, we didn't even have any 3D model or any navigation, conventional navigation, as you're all familiar with. We just had two dots, as you can see here on the screen. We had a green dot or a red dot. That's like a pre-planning that we did over a CT scan to guide us through. So basically, we see the green and the red, and we go from the red to the green, and we get there. But now it evolved into something that looks like this, as you can see at the bottom left image, where you see the spine in 3D, beautiful 3D model, and then you have also the conventional views, the sagittal and axial view of the patient images. We did before we did any cadaver or any human trials. We did a goat trial, and like I said, I mean, one of the surprising things was, to me at least, was that my strategy to go to do early marketing actually gave me all the connections I need, including the connection with Johns Hopkins surgeons such as Dr. Camilo Molina and Dr. Dan Shuba, who is with us today. And you can see I shared with you the first ever email that Dr. Molina actually sent me. He sent me it over to the website, I think, or no, it was directed to me, but it was through the website. He just noticed on our technology, and he said that he's working on Johns Hopkins iStar laboratory, and he thinks that we have something very interesting that we do. So we took the system, and we went to show him what we are doing there. Because, you know, I know the reputation of Johns Hopkins. They have very, very good surgeons, of course. And I wanted to, you know, to bring them on board, or to get their feedback. And we traveled around. We had like a system, a demo system that we carried in a Pelican case all around the world. I can tell you now, this Pelican case was new. It has no stickers on it, but it traveled around the globe, I think, in about 50 countries. I'm not exaggerating. 50 countries it is. Like now, it's covered with stickers, and you cannot even see any black plastic on it. And that was the first ever cadaver lab in 2016, more than 40 years ago, when Dr. Molina tested the system in Vista Labs in Baltimore. That was the first ever time that he used that he looked at our system.
That's incredible.
And you can see there in a small computer, you can see there the what he sees. I mean, you have 2 eyes, of course. That's what you, I mean, in the brain, it becomes like a 1 3D image. And let's keep forward here. And then you see also Dr. Steve Lewis was there. He's also one of our advisors from Canada, from Toronto. K2M was generous enough to bring us some instruments, and we tried it. That's a very, very early prototype that we had back then, obviously. Since then, we actually improved our labs and instrumentation, and we brought more surgeons to experience it, including Dr. Shuba, and we had some surgeons from Israel, and this early marketing also got us the funding. One of the great things about about working with the industry is all the connections that you can get. So we actually got a very interesting email I got on the website. Again, I was not familiar with anyone in that space. I didn't use any of my connections. So so one of the surgeons, Dr. Daniel Buchbinder from Mount Sinai, he serves as one of the board members of the AO Invest, which is the VC arm of the AO Foundation. AO Foundation is a leading orthopedic organization, nonprofit, and they decided to invest in startup, and that's how we got the investment from them, from the AO Foundation. We in 2017 we got the Series A raised, which is a $7 million, and we became a serious and big company with nice offices and facility that can turn this proof of concept, the idea that I had, into a real product that surgeons can actually use. So we moved to a nice building, and we started to build a bigger team. As you can see, we had about 20 people there, a lot of engineers. We continue to do cadaver labs. You can see there in the picture, Dr. Tim Witham is using the system in the lab, and all these labs attracted a lot of a lot of attention from all over industry, residents, students, everywhere, and it was pretty fun. Actually got the interest of Professor Ross Taylor. I'm sure that some of you know him because he's also from Hopkins. We were running most of our labs from Baltimore, in Baltimore. I mean, that was like our home base to do all the, all the trials. So we feel like we're home working with Hopkins staff. And we did also integration with partners, because we, that we need to get, we're basing our navigation on, with through a CT scan that we get, or intraoperative CT scan. So we worked with some partners. And when we did everything we did, when we did these labs and integration projects or demos or anything, everything just broke, right? I mean, it never works the first time. So I used my hotel rooms as a lab. So I always took the instruments or the headsets that we had, and I had to disassemble everything. Like I can't remember one time that everything worked. Never. I mean, it always broke, and I had to fix it. So I brought all the instrument, all the fixing, all the tools together with me to open it in my hotel room to start, soldering things. We had a lot of demonstrations in Davos during the AO Foundation, because now that we're partners to the AO Foundation, we started to participate in their annual courses, which also gave us a lot of exposure over there. And in 2018, we got our first in human eventually. It was with a wired version of the X Vision of our headset. So you can see here, and to the left, you can see the wires coming from the headset going all the way until they, you know, to the cart. And obviously in this setup, we cannot have two headsets working in parallel. So that was a limitation, but you know, it was good enough to prove the concept and to do some accuracy trials with our system in live patients. So the first in human was only 2 years ago, and you can see how it looks. That trial was done in Israel, yes, in one of the leading hospitals there. And very, you know, really short after we started to develop our wireless version, because we realized that we can never, sell, one single headset that is connected with a cable to a cart. Very not convenient to anyone. So we switched to a wireless version. It was not an immediate step. I mean, it took us, it took us relatively short time to do it, but to me, it looked like ages. That was very painful process to start everything and to develop everything from scratch, and we did it eventually. And we developed a cart, which we changed now, but we developed a user interface to support and to control two wireless headsets. With this, that's how our user interface looks on the workstation. And then we did a lot of trials with that. We worked with AO Foundation surgeons over there. In the picture, you can see them. We had multiple labs, and eventually we, in about half a year, like 6 months after we did the first in human, we switched the trial to a wireless version. And in a wireless version, that's much more convenient now. And that's how it looks. And now that we had like a system that we can be proud of, it's a wireless system, very accurate. We started to do shows, right? To go to trade shows. So we had the first big booth at NAS, North American Spine Society, in 2018, not that long ago. To me, it looked like, I don't know, if you would ask me how long was my first show, it was, I would say, like 5 years ago. But it's actually, yeah, only 2 years ago. I mean, unbelievable. So we had there, and then we also participated in other trade shows such as ISAS, where we actually met Dr. Frank Phillips. He's now our advisor as well. I mean, I didn't know him before, which is strange, right? But you know, he expressed real interest. And there's Dr. Hochschuler, and we have Isa Liebergal. And then we continue working on you know, demonstrating and showing, and our booth just got, you know, expanded. And because of the amount of people, I mean, there were like a lot of people interested to see what we have. So we had to have actually 3 you know, stations so we can accommodate everyone. The success was you know, very dramatic, right? I mean, it was I mean, the exposure that we got was exponential. I mean, and we couldn't sustain it all, you know, in a small company like we had. So I decided that to expand the company and to bring and to build a commercialization company in the United States. And together with Tim Moravsky, we started a company in the US, and Augmetics Inc. And we started to bring the people to this company. We had like a training classes, and now we have about 20 employees. Sorry, we had 20 employees, but in that day, I mean, that was the start. Now we have almost 40 now in the United States, only commercialization company. And you can see the amount of people that were crowded. I mean, every time that we did a trade show, now with the COVID, obviously it's not possible anymore, but every time we did a trade show, our booth was like packed with people standing in line just to see the headset. That's why we had to bring all these people. But old habits die hard. That doesn't matter how big your company. I'm always an entrepreneur in my soul, and you know, whenever something breaks, I just fix it. So It was not that long ago that I still fixed my headset, the headsets in the trade shows there. We continue, as a startup, we continue raising money all the time. So there's Dr. Molina is joining us there and helping the company. He's a true friend and a true contributor to the company, and he helped us even in that. We switched mode from development to get the product approved by the FDA. So we worked about half a year focusing only on getting the FDA approval. We did tons of tests, millions of tests that the FDA asked us to do to prove the accuracy or the latency or the cleaning, how we clean this headset to make sure that it's not contaminated. The accuracy test, the visualization, the depth perception, divergence, convergence, anything that you can imagine. Latency of the system. We used a very unconventional method to test it all. Again, there's no product on the market, and I don't see anything that comes close to a product on the market that serves for medical or surgery in navigation. So and now that we did the FDA test and we know all the questions that they asked us, we understand this is super hard. Okay, super hard. One of the final things that the FDA requested us to do is a cadaver lab, a final cadaver lab on a minimally invasive, because they were not satisfied on our cadaver trials that we did in open. So they wanted us to put roughly 100 screws, minimally invasive, and to show the real accuracy of where the screws are compared to, to the navigation. And we did it at Rush. We set up the lab in few weeks just to get the FDA done. And we placed 93 pedicle screws and 20 Jamshidi needles. Out of the 93 pedicle screws, we had only one screw that had a pedicle bridge. Pedicle is the bone that connects between, the body of the vertebra to the posterior part. Anyway, we got 99% accuracy placing the screws, which was amazing. I don't think that I didn't see any better study. We were almost 100% accurate and everything, and that and this is the accuracy from the FDA summary.
And then Nissan, and then you got to the Johns Hopkins surgery. Is that soon?
What's that? Sorry.
Johns Hopkins. Time check. When does Johns Hopkins do their surgery? It's got to be coming up soon, right?
Yes. Johns Hopkins are doing the surgery. They already started doing the surgery, and we got the FDA clearance, which is right after that. This was the install base. So obviously Johns Hopkins is here. Johns Hopkins is the first institute in the world actually that did the surgery. We had we celebrated it right after the FDA. We got it and we started to set the systems. We have other hospitals now that are using the surgery, and you can see here some of the clinical experience. This was in the recent months. I'm talking about like 2 or 3 months ago. You see Dr. Witham here in one of the TV shows. The TV broadcast and. For Dr. Frank Phillips, and we have Dr. Lynch, and with that ends my presentation. And I would like maybe we can have like a first-hand.
I was gonna say, Dan, tell us. So why is this so great?
Yeah, no, thank you for the invitation, Mark, and Nissan again. Thank you for involving me in this. It was great. So I'll just rapidly tell you some of my thoughts. So for the people listening, so this basically was brought to us, and we did the first cadaveric study, and we published it. So I think this was something that Nissan and his team really enjoyed, and we really enjoyed. So it was a really combination of entrepreneurial, smart engineers, and people thinking about how to use this, and then to academics. We did it, and I said, if we're going to do this, we're not just going to have newspaper articles. We're going to have this published in the Spine journal with peer review, and we did that. And then I got to play with it more, all those different devices. And then I got to go down to the FDA and help Nissan and his team pass this. So all these steps to me were great entrepreneur lessons. The bottom line is that it is truly disruptive in the operating room. And I think that's probably the most important aspect. So we can talk about the steps, but really the secret is that it's a great product. And what it does is imagine, I think one of the best examples I've heard, and I've kind of elaborated on this, is if you're driving your car and you're using navigation, which has been around, as Nissan said, for a long time, especially in the brain and even the spine. But there's this thing where you're driving your car and in a really bad traffic jam at a really important time, you don't want to look down at your dashboard or your phone, which is not directly in front of you. And so that's kind of what I would compare this to surgery, that if you are looking off and having what Nissan used the term attention drift, you're basically taking your eyes off, say, the spinal cord of the brain, and you're looking at a monitor, and that's not natural. And I think people who use a lot of navigation have become good at that, despite the fact that it's not intuitive. And so what Nissan's vision was, and which it has really become for me, is you can actually look at the operating table or the patient directly in your most comfortable position as you've trained as a surgeon, and now with an onlay. Remember, this is augmented, not virtual. This is augmented. So you're seeing the patient, but onlaid on top of that are the spinal elements that you want to add, and you can turn them on and off with a foot pedal. So if they're bothering you, turn them off. If you want them, add them on. And the idea, I guess I would say, back to the car example, because most people know what I'm talking about when they're driving, is now, I guess my idea would be that you're looking at the road in front of you, and there's a giant green arrow on the road pointing to the left turn as you're coming up to it. That's pretty much more what this is like, as opposed to having to look at a dashboard and do a little bit of a transition between what's looking on the map to what's looking on the road. You're actually looking at the road, and there's a big green arrow showing turn here. And so there's no green arrow saying to do operate here yet, but the idea is that it's actually showing you all the anatomy that we want to know. And it's been great. A lot of my, personally, a lot of my friends and colleagues throughout the country know that I'm a little bit of a traditionalist, and I like the classic ways to operate, and I'm very proud of that. And so a lot of people are calling me saying, Dan, if you're liking this, it must really work, because you're not the guy. I'm not the guy in the beginning of that innovations curve who accepts things. In fact, I'm the guy, shaking my head and rolling my eyes maybe until the next dip or what have you. So this was something that I jumped on early because it was truly game changing. And I'll tell you just one anecdote, and then I'll take a break, is that when we were doing one of the cadaveric labs in Baltimore, we had a non-surgeon play with it. And I put in screws on my side, and this person who's never put a pedicle screw in through the skin. So no visualization of the spine, just following the navigation, like I said, on the car, like never really drove a car, but just following the map, if you will. And then we did a CT, and the screws were identically perfect. And you could say, oh, good for you, Dan, you put screws in, but I've been doing this for 20 years. And the person had never put one in, and his screws were identical to mine. I said, this is truly disruptive that someone doesn't know how to put in implants can do this, use this device to put them in. And it was quite humbling. I was very excited on one hand and also crying inside a little bit, going, wow, I'm replaceable that easily. So all joking aside, very disruptive and very exciting. And once we got to the FDA, I mean, I think what Nissan kind of alluded to, and it became, it was this fire that really kind of started burning, and the exponential rise was fantastic because people see it and they really like it. Now things are getting big. I think this week alone, thanking you for this invite, I think I did 2 other interviews for other newspapers or journals on this just this week alone. And so you can see how exciting this is, and it's really nice application. So I'll stop there.
Dan, a quick question. So does this, obviously it makes you more accurate. I mean, there's no doubt about that, but does it speed things up? I mean, relative to how you used to do surgery, does it make it, I mean, tell us more about kind of what your experience is in the operating room.
Yeah, I think that the way I would respond to that is, there's always trade-offs in life, right? So what you'd have is you say, hey, I'm going to do this surgery open, not minimally invasive, open, so I can see all the anatomy, and then I'll see more and I'll do more. But then you give up the fact that you could probably do this minimally invasive. However, if you try to do it smaller and less invasive, so you're not destroying normal tissues, you have to cheat with something else because you can't see it. So now you have to do a lot of fluoroscope, a lot of X-ray. You got to bring in a new device, a lot of X-ray radiation. You got to do a navigation, or maybe even a robot. And that extra device adds significant time and change in workflow. So you might say, well, Dan, come on, man, get with the times. If you're an old school surgeon and you're like, you can make a smaller incision, why wouldn't you adopt a navigation system like Nissan originally said his experience with Medtronic's Stealth system was? And I'd say, because in the early times that added hours to a case that might have only taken a couple hours. So you do an operation that was 2 hours long under anesthesia, open, and maybe the navigation would be 4 hours long. And so the surgeons would say, I'm not making a small incision, I'm just doing it the old fashioned way. And a lot of people didn't adopt it. And then the people who were really good pioneers did said, well, I can do this in 3 hours. And when you bring in the machine, you bring in the robot. And so what happened was old school surgeons who were fast would still say, it's just not worth it to me. I'd rather have less anesthesia and see more than playing with an extra toy. And so what I think Nissan's group is doing is they're saying, I put this thing on my head, I operate whether it's MIS or open, and I immediately have the device. I don't have a big camera. I don't have a big tower. I don't have a big robot. So you're kind of getting the best of both worlds. You're having the workflow still, with a headgear. We're used to wearing headgears and glasses and microscope, loop magnification all the time. It's the same thing. It doesn't change it. And I just operate and I hit a foot pedal and say, turn on the navigation, and it's immediately there. So I think that we're now getting the efficiency, which is still safe, right? If you have left anesthesia, you're safe, with a smaller operation with the navigation accuracy, as you said. So now you're getting safety plus efficiency, because before safety cost a lot of time and cost a lot of money for that matter, and maybe cost a lot of headaches for surgeons, and maybe cost a lot of anesthesia to the patient. So now the cost of that accuracy has become a lot cheaper because now you're wearing on your head and you're able to move quickly. So I think efficiency and accuracy are extremely important, and I think you're getting both with this.
So you have a less crowded operating room because you don't have all this extra equipment. You just have this thing on your head, which is something you're used to. Because that was going to be my next question, is user experience of wearing a thing on your head, but it sounds like that's not a big deal.
Yeah, so most of us, at the minimum, so, orthopedic and neurospine, there's very little difference at this point, but traditionally, neurosurgeons would wear loop magnification. A lot of orthopedic surgeons wear that now. And most of us wear headlights because we just want that super bright light down in the crevices that the standard lights can't see. So most of us are used to wear something on our head. And what's nice is that, even sometimes where I wanted to go through loop magnification with the augmetics. So for example, if I wear loop magnification, I get tired of wearing it. So I'll take it off and someone just pulls it off. I just turn my head and someone pulls it off. And so during one of the early cases, I used my loop and then I used the augmetics and I basically said, take this off and put it on. It literally was about 30 seconds where they would just take off one and put on. It's like basically someone, you go to the eye doctors, you go to the people who try your frames out the store, and they put the frames on for you instead of you doing it sometimes. That was basically what I'm doing the operating because I'm sterile, and they would just put it on and then take it off. So even when you want to take it off, you can take it off and it's still registered. So I put it back on a couple hours later versus the old system, bring in this lumbering robot or rehook it to the table. And then you decide, I don't want this robot. I want to kind of operate for a few hours after the robot. Sorry, man, you should have thought about that because that's like saying, just move this building 2 inches to the left. I mean, that sounds simple, but it's a lot of time and effort. This was so nice that I could take it off and put it on the counter and say, hey, I actually changed my mind. An hour later, I want it back on, and it was immediately there for me. Or you leave it on. And a lot of surgeons have talked to me and say, do you get the people who don't like to wear headgear say, I don't want to wear a headgear for 8 hours if my surgery is 8 hours. I said, you might only need augmetics for an hour of it. Take it off and put it back on. And they go, oh, that was my biggest fear as a surgeon. And I go, yeah, that's like not an issue at all. So those are little things that, for non-surgeons who are listening, it's a big deal when a surgeon finally feels comfortable with what he or she is doing and finally gets some flow. It's like I'm not saying I'm an elite athlete, but it's like those elite athletes who want a very specific bat or a very specific shoe. And then when someone says, can you change shoes today for the big game? You're like, this is a big deal. This is patient surgery. So this is something that actually is quite intuitive, and a lot of people are adopting it for those easy reasons.
Great. Nissan, a couple of questions from the audience. Talk a little bit about how does this integrate with Medtronic's product, or is it a complete replacement, or are there other systems? How does Magic Leap play into all of this? Questions like that.
Yeah, so there are, since we started, there are other off-the-shelf products, more consumer-based products, such as the HoloLens and Magic Leap that you can take it and use it and maybe connect it to traditional navigation system. But what we have developed is a headset that is a traditional navigation system. So you don't need an additional system that costs like $500,000 to a Medtronic Stealth Station and to use, and to project all the items. If someone already have the system, traditional systems, I can imagine, theoretically, I don't know, nobody has done that. I mean, it's not like a proof product, but theoretically speaking, yes, you can take something off the shelf, same as you could do it like 20 years ago, right? I mean, augmented reality glasses or technology was exist for 20 years. So you could always take something and put it on your head and use it as a near eye display. But the HoloLens and Magic Leap and other products that may be will not serve. I mean, currently, I cannot see them being a complete navigation system by their own. Only as a near eye display that is possible. Our system is as a complete navigation. If you can, if that's the main difference between what we do and other products, which are only a display.
I would say, from my experience having started companies, I think you've crossed a bunch of amazing bridges. I mean, watching technology innovation, first you got it to work. Question, that's always issue number one.
Yeah.
Two, you've passed FDA approval and accuracy, and it sounds like you were a test case, a litmus test case for sort of this new era of technology, because I think there's going to be more of this. And it sounds like they really put you through the paces. And I think three, and perhaps most importantly from my experience as an entrepreneur, is you figured out the user experience. And I think that is where 9/10 of companies fail, is that they get to a point where they've got this great product, but they can't get anybody to use it. It's too complicated and too hard. So Dan, thank you for your contribution there. I think that's super helpful to hear sort of the end user's experience, and also sort of, what's the benefit to the patient at the end of the day. It sounds like it's safer, faster, cheaper, better. It's all good. So I think that's great. Two last questions for you, Nissan. What was the biggest challenge you faced in sort of bringing this thing to market? And so where do you go from here?
We're still, we still have a lot of challenges ahead of us. Right now, I'm in Chicago now in our, commercial company here. So we're thinking hard, brainstorming on how we bring it to the market in a more efficient way. I think that spine surgeons, and Dan can actually can testify, they're very unique users. They don't want to work the system by themselves. They want something there, someone there to help them. I think and that's a fault that most companies, hardware companies, actually made throughout the years. So they're very dependent on the reps. Okay, there's a reps in the room. They help them with the instrumentation and with the navigation and everything. And the challenge here is how we actually make money out of it. Okay, so we have the great technology, we have the great user experience, the need is there, and now comes the moment where we are going to the market. We have our pricing, and we need to crack something which is, every time that we pass one barrier, it just becomes even harder now to pass the next one. And now the barrier is how we grow this business, how we grow and still make a lot of money and not bleeding a lot of money. Many companies just, sell like robots for millions, and, they can sell, I don't know, like $100 million a year, but still lose money, right? And the trick is how we make it a sustainable business, so it will sustain itself at some point, and we can deploy the systems around the world and be a very successful company. So right now we are thinking, everything about it, and who's going to support cases, who's going to install it, and that involves also some technology improvements that we do to make the system more autonomous, more easy to use, easy to install, that like encapsulates everything all together, I would say. So challenges are not over yet, and that's a major challenge now that we're facing, but we're going to solve it, same as we solved everything else.
So you started with spine. What comes next? What brains,
Right. So
Yep, slide.
yeah, the applications are endless. I mean, anything that you want to increase the accuracy of surgery when you treat a patient, or not just surgery, right? Any treatment that you want to have like super accurate, you can use our system. We started with spine because that's the low-hanging fruit that we think it is, and then we moved to brain surgeries. Yes, for sure, craniotomies. And followed by joints, hip and knee, arthroplasty, ENT surgery that is widely used, navigation is widely used in ENT surgery. So I think, and anything, I mean, biopsies, anything that you want to treat a patient with high accuracy, I think our system can come very handy.
Well, you certainly didn't start at the easy scale. You started with spines and brains. So obviously you're not going the easy route, but our time is about up. I appreciate both of you guys. Thanks, Dan. Thanks, Nissan, for being with us today. I appreciate you taking the time out of your busy schedules and talking a little bit about the X-Vision system. This sounds really fantastic, and much success to both of you.
Thank you, Mark.
Thank you very much.
And thank you again for this great panel.
No, this is great.
Good day.
For the rest of the audience, we will be back at 10:20 with our next speaker. So there's about a 15-minute break here. Thanks very much.